Welcome, everyone. We're doing a focused deep dive today, aimed specifically at surgical residents prepping for boards like the FRCS.
That's right. We're zeroing in on patient and wound assessment.
Really distilling those core principles you need for evaluating surgical wounds effectively.
Exactly. It's all about optimizing outcomes. And that starts with a solid, systematic assessment.
A systematic approach is definitely key. We're thinking patient evil, wound evil, labs, imaging.
Assessment, plan, execution, that whole sequence.
Okay, so let's kick off with patient evaluation. What are the absolute must-knows for residents?
Well, first, think algorithmically. It's a process. Start with the basic demographics. Age is a big one.
Right.
Then you really need to drill down into their general health. Comorbidities are huge.
Which ones should be top of mind? The ones that really mess with wound healing?
Oh, definitely. Diabetes, for starters, end-stage renal disease, major cardiac issues, PVD,
Peripheral vascular disease, yeah.
tobacco use, any history of vasculitis,
Hmm.
malnutrition that's critical steroid therapy, prior radiation, they all play a role.
And you mentioned hemophilia specifically.
Yes, for hemophilia, you're aiming for that perioperative factor 8 level of about 80%. That's a key number.
Got it. And what about their baseline function?
Crucial. You need to know their pre-wound functional status, their
Mhm.
ambulatory capacity. It sets the context.
Okay, moving to the physical exam, what are the high-yield assessments here?
Vascular, vascular, vascular. You need to palpate pulses, check skin temp, look at hair growth patterns, any skin changes.
Signs of perfusion.
Exactly.
Got
Gives
it.
you a direct window into their blood supply. And don't forget neurosensory.
Mm.
Reflexes, sure,
Mm.
but also things like two-point discrimination or vibratory sense.
Using the 128 hertz tuning fork.
That's the one. Really important if you suspect nerve involvement.
Makes sense. All right, let's shift focus to the wound itself. What history details do we need to capture?
You need the story. How did the injury happen? The mechanism.
Uh-huh.
Have they had wound healing problems before? Is this wound chronic? How long has it been there?
And what's been done already?
Precisely. Any previous tests, treatments, dressings, get the full picture.
And for the direct wound examination, what are the core components?
Location, first off. It can give you clues about the cause.
Like a pressure ulcer location versus a venous stasis ulcer.
Exactly. Then size, you absolutely have to document length, width, depth, get an area measurement if possible. It's vital for tracking.
Objective data.
Right. Then define the extent, what layers are involved. Skin, subcutaneous tissue, muscle, tendon, nerve, bone. Spell it out.
Okay. What about the surrounding area?
Also key, look at the surrounding skin and the wound edges.
Yeah.
Note the color, any pigment changes. Is there inflammation, induration, satellite lesions, edema?
And then the wound bed itself.
Yes, the bed tells you a lot. Is there an odor? What kind of necrotic tissue slow, Escher? Is there healthy granulation tissue? Are structures like tendon or bone exposed? Fibrin, exudate.
Foreign bodies.
Foreign bodies, definitely. Signs of infection, obviously. And look carefully for any undermining tunneling or sinus tracts.
That requires careful probing.
It does. Okay, let's talk labs. What are we looking for?
What key data points do they give us?
Well, they add important pieces to the puzzle. A CBC, for instance. High white count, left shift, suggests infection, right?
Pretty standard.
BUN and creatinine gives you renal function, hydration status, glucose, and HbA1c.
Glycemic control. Always important.
OAS. Immediate glucose tells you about current control. A1c gives you the long-term picture, like the last 120 days.
There's some debate about tight control, though, isn't there?
There is. Some studies show benefits of tight control, like under 110 milli-GDL, reducing mortality, but others show increased risk with hypoglycemia, especially in critical illness. Perioperative hyperglycemia, say over 180, definitely ups infection risk.
But the A1C itself doesn't directly predict SSIs.
Interestingly, no. Elevated A1C doesn't seem to correlate directly, even though poor control overall does increase risk. A normal A1C is around 6.0.
Good distinction. What about nutritional markers? Albumin, pre-albumin.
Absolutely critical. Albumin, with its longer half-life, about 20 days, is a major predictor. We talk about mild, moderate, severe malnutrition based on levels. Below 2.1 GDL is severe.
And it's a big predictor of mortality.
Huge. One major study found it was the most important predictor of 30-day mortality after major surgery.
Wow. And pre-albumin.
Shorter half-life, about 3 days. Useful for tracking changes more quickly. There's the rule of fives for deficiency levels, normal over 15 milli-GDL, severe under 5.
But they have limitations.
They do. Both can be thrown off by infection, inflammation, recent trauma. They're not perfect in those acute settings.
Okay. And ESR-CRP.
Non-specific inflammatory markers, useful for a baseline and particularly helpful for monitoring potential osteomyelitis recurrence after treatment.
Right, tracking trends. Let's move to imaging. How does that help?
Different tools for different jobs. Plain x-rays are good for fractures, big foreign bodies,
Huh.
but they're not great for early osteo.
Sensitivity and specificity aren't ideal there.
Exactly. CT scans are better for looking at abscesses, figuring out the extent of the wound, finding tracking or tunneling.
NRI?
MRI and MRA are really the go-to for suspected osteomyelitis, much higher sensitivity and specificity. And MRA is great for vascular assessment too.
Along with traditional angiography.
Right, angiography is still a primary tool for detailed vascular mapping, though contrast-enhanced MRA is catching up, very accurate for peripheral arterial disease, and patients often prefer it.
Important point, though, about preoperative imaging for free flaps.
Yes, a normal scan doesn't guarantee you'll find good vessels to hook up to when you get in there. You still need to be prepared.
Good reminder. What about other diagnostic tests, things we do at the bedside or clinic?
Handheld Doppler basic, but useful for checking for pulses, assessing flow quickly.
Uh-huh.
Then the ankle brachial index, the ABI, really important for quantifying PI.
Can you quickly recap the ABI ranges?
Sure. Over 1.2 suggests non-compressible vessels, often calcified. 0.9 to 1.2 is normal. 0.5 to 0.9 is mixed disease, moderate impairment. Below 0.5 indicates critical stenosis, severe ischemia, and below 0.2, ischemic gangrene is likely.
Okay. And TCPO2, transcutaneous oxygen.
TCPO2 measures tissue oxygen levels.
Huh.
Normal is above 40 mmHg. Below 30 is generally considered abnormal, suggesting significant hypoxia. It could also show if the hypoxia might respond to supplemental oxygen.
Useful for predicting healing potential.
Exactly. Then, of course, culture is essential for identifying the bugs and their sensitivities, and biopsy.
When you biopsy a wound?
If you suspect vasculitis, definitely.
Yeah.
Or if you're worried about malignancy in a chronic non-healing wound, a Marjolins ulcer, remember those can take decades, average 30 years to develop.
Right. Or pyogenic granuloma.
Yes, biopsy helps differentiate that too.
Okay, so we've gathered all this info. History, exam, labs, imaging, tests. How do we pull it together into an assessment and plan?
Right, the synthesis. Your assessment needs a clear working diagnosis. What do you think is going on? What are your treatment goals? And how will you measure progress?
Measurable parameters.
Absolutely.
Yeah.
Then, the plan. This is where the reconstructive ladder, or maybe nowadays the reconstructive matrix, comes in.
Tell us about that evolution.
Well, the traditional ladder, Mathis and Nahai's concept, started simple secondary intention, primary closure, skin grafts, and moved up in complexity to local regional free flaps.
Right, simplest first.
Then Gottlieb and Krieger added the elevator idea, maybe jumping steps.
Yeah.
Janus and others incorporated newer tech like dermal matrices and NPWT.
Dermal matrices, how do they fit in?
They're collagen-based scaffolds, basically. They integrate, get vascularized from the wound bed,
Yeah.
and can create a sort of neodermis. Useful for covering exposed structures like tendon or bone, can improve skin graft appearance, simplify tricky areas like the scalp.
Any downsides?
Sure, seromas, hematomas, infection are potential complications. You have to manage them carefully.
And the reconstructive matrix.
That's a more modern concept, like the one proposed by Erba et al. It considers not just surgical complexity, but also the technology available, patient risk factors, aiming for an optimal solution, not just the next rung on the ladder.
So the modified ladder today might look like primary closure, secondary intention, NPWT, skin graft, maybe dermal matrix, local flap, regional flap.
Distant flap, tissue expansion, free tissue transfer. It's still a valuable framework for systematically thinking through options.
But free flaps aren't necessarily the absolute last resort anymore.
Not always.
Yeah.
Sometimes, for a complex defect, jumping to a free flap early gives a better, more definitive outcome than multiple smaller, potentially failing procedures.
Makes sense. The best tool for the job.
Exactly. And things like tissue expansion or prefabricated flaps allow for really sophisticated reconstructions while trying to minimize donor site issues.
Okay. What about adjuncts to wound healing? Things we might add on.
There are several. Hyperbaric oxygen HBO has shown some benefit, particularly for diabetic foot ulcers and osteoradionecrosis. Platelet-rich plasma, PRP, lots of growth factors. But the high-level evidence is still a bit lacking, and preparation methods vary a lot.
Stem cells.
Huge potential for regeneration, skin, bone, cartilage, using adult stem cells from marrow, blood, fat. But again, mostly still in the research phase, needs more robust evidence for routine use.
What about something low-tech like honey?
Actually, yes. Medical-grade honey has proven antibacterial properties against bugs like Staph aureus, E. coli, Pseudomonas.
Interesting. And biologic
There's
dressings.
a whole range: Alloderm, Integra, Dermagraft, Apligraft, BioBrain, others. They have different compositions. Some are acellular dermal matrices, some contain living cells, used in specific situations.
And negative pressure wound therapy, VAC therapy.
VAC is widely used. The mechanism involves increasing blood flow, promoting granulation tissue, cell deformation, stimulating healing, removing fluid, maybe modulating cytokines.
But it has contraindications.
Definitely. You wouldn't put overexposed blood vessels, known malignancy in the wound, untreated osteomyelitis, unexplored fistulas, or in grossly infected, unprepared wounds.
Okay. So, wrapping up, what are the big picture considerations when making these decisions?
You always have to think about the functional impact of the wound and your proposed treatment. How durable will the reconstruction be?
Right.
And you must individualize. Patient factors are key, including socioeconomic things. How long will they be in hospital? How
Yeah.
many surgeries? When can they get back to work?
Aesthetics matter too, of course.
They do. But the guiding principle should always be make sure the solution isn't more complicated or morbid than the original problem. Keep it appropriate.
Excellent point. So let's recap the absolute key takeaways for residents heading into their boards.
Okay. Number one, a comprehensive clinical evaluation patient, comorbidities, wound itself is absolutely fundamental. You can't skip steps.
Bedrock.
Number two, optimize what you can control. Blood glucose, nutritional status pre-op and post-op. This is crucial for preventing complications, especially infections.
Got it.
Three, remember that preoperative serum albumin level? It's a really significant predictor of post-operative mortality. Don't ignore it.
Critical point.
And finally, use modern reconstructive algorithms, ladder, matrix, whatever framework you prefer. Think systematically, but tailor the plan considering the specific defect, the available donor sites, the patient's overall condition and preferences, and your own expertise.
Fantastic summary. Thank you for breaking that down so clearly. This systematic, thorough approach is just essential for board-level practice and beyond.
Absolutely, it forms the foundation.
So for everyone listening, keep studying these principles, apply them consistently, and remember that initial detailed assessment truly sets the stage for successful surgical outcomes.